Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article Maintaining Outstanding Outcomes Using Response and Biology-Based Therapy for Intermediate-Risk Neuroblastoma, a report from the Children's Oncology Group study ANBL0531 by Twist et al. My name is Javed Khan, and I am Deputy Chief and Senior Investigator at the Genetics Branch and an attending for the Pediatric Oncology Branch of the National Cancer Institutes of the NIH in Bethesda, Maryland. My oncological specialty is pediatric hematology oncology. Childhood cancer is a life-threatening disease where survival rates have increased exponentially to over 75% over the past 3 decades. However, this has come at a considerable cost, with significant incidence of late effects including hearing loss, scoliosis, hypothyroidism, growth and developmental delay, infertility, psychological, emotional, cognitive and neurological sequelae, and secondary malignancies. Most of these late effects have been attributed to therapy, including chemotherapy, surgery, and radiation. In this manuscript that accompanies this podcast, Twist et al. Report on the results of the Children's Oncology Group study ANBL0531, whose primary aim was to reduce therapy for subsets of children aged less than or equal to 12 years old with intermediate risk neuroblastoma, using a biology and response-based algorithm that assigns the length of treatment duration while maintaining a 3-year overall survival of greater than or equal to 95% for the entire cohort. Neuroblastoma is an extracranial pediatric malignancy of neural crest origin that has been described as an enigmatic cancer due to a significant clinical, molecular, and biological heterogeneity. For example, some patients with widely metastatic disease are cured with minimal or no therapy, whereas others have relentless progression to death despite intensive therapies. There has been considerable progress in dissecting out the causes of this heterogeneity and developing prognostic markers to stratify the risk based on several clinical, histological, and molecular markers. At the time of this clinical study, when this was performed and the manuscript was written, the authors stratified patients using several clinical and biological parameters, including age, the International Neuroblastoma Staging System, MIC-N amplification status, and the International Neuroblastoma Pathology Classification of Histology, and Tumor DNA Index. An additional marker utilized in this study was loss of heterozygosity determination of the tumor at chromosome bands 1p36 and 11q23. This stratification strategy has led to the identification of low and high risk groups where therapy is more clearly defined, and patients with low risk have excellent outcome for most patients with surgery alone and watchful watching. For high-risk disease, significant strides have been made using a combination of surgery, aggressive chemotherapy, radiation followed by chimeric antibody 1418 anti-GD2 therapy, GM-CSF, IL-2, and isotretinoin. However, the 5-year-old survival remains guarded at 40 to 50%. In the intermediate risk group, which is the subject of this study, although the 5-year survival rate of 90 to 95% have been achieved, this group is significantly heterogeneous. raising the possibility of reducing therapy for subsets of patients within this group. This was the motivation for this study. Thus, the goal of this clinical protocol that is reported, the ANBL 0531, was to refine the minimal therapy needed to achieve excellent outcomes for patients with intermediate risk neuroblastoma, with the aim to maintain overall survival rates of greater than 95% for the entire cohort. Patients were stratified into groups 2, 3, or 4, who were assigned to receive minimal of 2, 4, or 8 cycles of chemotherapy, respectively. Chemotherapy was identical to that used on a previous study, the A3961. Reduction of therapy was planned to be achieved for patients with biological favorable tumors, that is group 2 and 3, by using the achievement of partial response to therapy, with or without surgery, to be the endpoint of therapy, rather than the achievements of very good partial response, as was previously used on A3961. If the treatment endpoint was not achieved after completion of the scheduled chemotherapy courses, additional cycles of therapy could be administered, and patients re-evaluated following every 2 cycles to determine if the treatment endpoint has been achieved. VGPR, or very good partial response, is a more stringent response criteria, was used for group 4 patients, which included those with age of less than 365 days, stage 4 disease, MYC not amplified, and either unfavorable histology or DNA index or ploidy equal to 1. Patients with this subgroup received 8 cycles of chemotherapy on A3961, which was a reduction in therapy for these patients compared to prior studies. Group 4 patients, which also included 2 subgroups, who were previously stratified as high risk, including those who had stage 3 disease, age 365 to less than 547 days, stage 3 MYC not amplified, unfavorable histology, aneuploidy, and those with stage 4 disease, age 365 to less than 547 days, MYC not amplified, favorable histology, or DNA index greater than 1. These patients also received isotretinoin, or 13-cis-retinoic acid or Accutane, or maintenance therapy, as they would have previously received this treatment on high-risk protocols. Thus, these patients would receive significant reduction in therapy compared to previous studies. These patients were closely monitored by interim stopping rules. Rescue therapy for this study for patients with an inadequate response to initial therapy and for patients with progressive non-metastatic disease utilized standard cyclophosphamide and topotecan. Reduction of therapy was also planned and achieved on their study by reducing potential surgical morbidity for patients with stage 4 disease who would no longer be required to undergo resection of their primary tumor. In this manuscript, the authors report that 404 evaluable patients were enrolled between 2007 to 2011. They found that compared to legacy COG studies, subset of patients with loco-regional disease, infants with stage 4 or 4S disease, and toddlers with stage 3 or 4 disease had a reduction in treatment. The 3-year event-free survival and overall survival were 83.2% plus or minus 1.9% and 94.9% plus or minus 1.1% respectively. Infants with stage 4 favorable biology, that is 61 patients, had superior 3-year event-free survival to patients with greater than or equal to unfavorable biological feature. Number is 47. That's 86.9 plus or minus 4% versus 66.8 plus or minus 7%, and this is significant at 0.02. With a trend towards overall survival, 95.0 plus or minus 2.8% and 86.9 plus or minus 5.1% respectively, p equals 0.08. For patients with localized disease, overall survival was 100%. They conclude that comparable excellent survival was achieved with biology and response-based algorithm, with reduction of therapy for subsets of intermediate risk neuroblastoma patients. However, more effective treatment strategies are still needed for infants with unfavorable biology stage 4 disease. For the 32 patients with hyperdiploid favorable histology stage 4 tumors with LOH at 1p36 or 11q23 or missing LOH data, intensification of treatment on ANBL0531 compared to A39611 did not reduce the risk of relapse previously reported for infants with tumors that harbor these genetic abnormalities. 3-year event-free survival for this cohort was 68.6%. The 95th confidence interval was 52.2 to 85.1% versus 86.9%. The 95th confidence intervals were 78.3 to 95.4% for infants with favorable histology, and the significant level was 0.04. Overall survival was not significantly different, indicating that many of these infants with 1p36 or 11q23 aberrations were successfully salvaged. Of the 20 patients who received cyclophosphamide and topotecan due to an inadequate response to initial therapy, 9 achieved very good partial response. However, 6 of the 20 developed progressive disease or relapsed, and 1 died, indicating that more effective treatment is needed for patients who do not meet the defined treatment endpoint after 8 cycles of chemotherapy. So what is the take-home message? This is an important study with clinical implications for intermediate risk neuroblastoma, where the authors show that it is possible to reduce therapy based on clinical partial response endpoint compared to very good partial response. This most likely reflects the biology of the disease, such that the tumors that are responding to therapy will continue to involute. However, more effective therapy is needed for patients who develop progressive disease or relapse or do not meet the defined treatment endpoint after 8 cycles of chemotherapy, as these patients continue to have poor outcome. This will await the results of current biological and genomic studies and the development of novel therapies, including ALK or RAS, or epigenetic targeting of MECAN activation in these tumors, or immunotherapeutic approaches such as adoptive cell therapies consisting of chimeric antigen receptor CAR T cells or NK cells, or the use of immunocytokines such as humanized 14.18 IL-2 or antibody drug conjugates. All these holds promise for future substratification and new therapies for children with intermediate and high-risk neuroblastoma. This concludes this podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.